we've got Glen Westall. So we've been working with Glen for the last couple of years. He's based down at the Alfred Hospital. He's got a strange accent like one of our other speakers, but quite a bit different in that he comes from the UK. He's trained at the Royal Brompton Hospital in London, a clinician, an idiopathic pulmonary clinician, and he also has, the way that we got in touch with Glen actually was he has a research interest as well in looking for new drugs and working with groups like AdAlta to identify those next generation therapies for IPF. So Glen will introduce himself and get started.
Thanks, Sam, for that ever blunt introduction. I'm a clinician. I look after patients with idiopathic pulmonary fibrosis, and you've been hearing this morning about this wonder product, and I'm going to tell you why we need a wonder product. We're going to be talking about a condition called idiopathic pulmonary fibrosis. But before I drill into that, I'm going to just give you a little bit of background, a bit of context. We're talking about lung fibrosis. What happens to the lung when it becomes scarred? The lungs are like bellows. They go in and out. Their job is to pull in oxygen, take out carbon dioxide. And as the lungs become damaged, that function disappears. And scarring of the lung is what's happening. Fibrosis is the medical term for it. And as the lungs become scarred and fibrosed, the function deteriorates, they shrink in size, and they become stiff, and our patients describe breathlessness. And there are many, many things that cause lung fibrosis. Fibrosis is a response to an injury. There are many things that you inhale that can cause injury. And there are hundreds of things that can cause lung fibrosis. Physicians are very good at coming up with medical terms to keep our patients confused, and the term we use is interstitial lung disease, which is our medical term for a whole umbrella group of conditions characterized by this fibrosis and scarring of the lung. And we have kind of schematics that allows us to group different conditions according to what causes this fibrosis of the lung. And in there, you have what's called the idiopathic, and idiopathic, again, is a medical term, which means we don't really know what's caused it. There are things we do know that cause fibrosis of the lung. If you're exposed to asbestos, you'll get fibrosis of the lung. If you spend your whole life down a coal mine without airway protection, you'll get scarring of the lung. And there's some drugs that can cause it as well. But we're talking about something called idiopathic pulmonary fibrosis that represents about 50% of all the patients that we see with lung fibrosis, and it by far and away is the biggest single group. Again, to define the term idiopathic pulmonary fibrosis, fibrosis, scarring, pulmonary of the lung, and idiopathic, we don't know what's caused it. We know a few things about it. We recognize that males are slightly more prone to get it than females. We know that it's a disease that comes out of the blue, typically in your mid-60s, occasionally earlier, occasionally later. And whilst it isn't characteristically caused by smoking, it is noticeable that many people who have smoked do have it. But the relationship with smoking is not like that, but we have for another lung condition called emphysema. It's a condition that affects around 10,000 people in Australia, and it's quite clear that there are more cases today than there were 10 years ago, and therefore we expect the incidence to increase over time. And it's a very unfair condition. This is how it behaves. This is a graph showing how people's lungs track over time, and you can go through early adulthood, through adulthood into late adulthood with no problems whatsoever, and it comes out of the blue, typically in your mid-60s, and once it takes hold, it causes reduction and damage of the lung in a relatively rapid manner, such that at the point that you're diagnosed and told that you have idiopathic pulmonary fibrosis, your outlook is actually worse than if you were told that you had lung cancer, which is one of the biggest killers in this country. So it's a devastating condition in desperate need of an effective therapy. How do we diagnose it? So I said it represents 50% of all of our patients who have lung fibrosis. And one of the things we have to do is work out whether or not you've got idiopathic pulmonary fibrosis, or we've got one of the other things that causes scarring of the lung. We don't have a blood test for lung fibrosis that will tell us whether or not you have it. And the way we diagnose it is actually by having a meeting, not too dissimilar to this meeting that we have here, where we have X-ray experts, radiologists, we have pathology experts, and we have the clinicians who present the story, look at the X-rays and look at the pathology, and as a group say that this looks like idiopathic pulmonary fibrosis. And this is key because you need to, if you're looking for a new therapy, you need to make sure you're treating people which have the condition and you're not treating the other 50% of people who may have scarring for some other reason. Now this is how we have traditionally looked at treating this condition. We've been trying to treat this condition for many, many decades. And if you go back 20 years ago, we thought it was an inflammatory condition, that the lung was full of immune cells that were causing inflammation, making the lungs hot. And therefore, we spent many decades using medicines that dampen down the immune system, dampen down inflammation, using drugs such as steroids and other agents. And what was dramatic was that these patients did worse when we gave them these therapies than if they did nothing whatsoever. If we go back to 2011, a group of experts from around the world sat around the table and looked at all of the trials that had been done at that point and looked at the evidence for all of these drugs. And this committee basically said you shouldn't be using any of these drugs whatsoever. You should be against, you should not be using steroids and all the other drugs that are in that list. Basically saying that we are better off having no therapy than some of these experimental therapies. So it was really a very desperate environment as recently as 5-6 years ago. And you'll note that at the bottom here is this drug pirfenidone, but we're going to talk a little bit more. And in 2011, we still were not quite sure of whether or not this was a good guy or a bad guy. Now that changed all in 2014, which in a sense was a seminal year for lung fibrosis, where some very large studies were performed which showed that 2 drugs, one of which was pirfenidone, and you're going to hear a little bit more about that later on, actually changed the natural history of this condition. So for the first time, when we gave a patient a therapy, they did better than if they had no therapy whatsoever. And that was a game changer after many, many decades of negative trials, if you like. This is a busy slide, but we might just concentrate on this slide here. This is measuring the size of the lung and how it changes over time. And there are 2 arms to this study. Half the patients, 280 patients, took pirfenidone, and half the patients took placebo, a sugar pill. And what happened with those patients who took the sugar pill, the placebo, the lung size shrank, the lungs shrank over time, consistent with this scarring getting worse and worse and worse. And this is what we understand by this condition. If you do nothing, the lungs get smaller and smaller and the function goes off. And what you can see is that with pirfenidone, the lungs were still getting smaller, but at a much reduced rate. And what that means is that people were becoming less breathless and were going to be living longer. When they combined their data, they showed that those who were on pirfenidone were less likely to die and less likely to die from their disease. But it came at a cost. And the cost is that these drugs really had quite an unpleasant safety profile. Many patients would develop nausea, and many patients got a rash that was particularly worse in the sun. And that's particularly of relevance in the Australian context where we love spending our time outside. So these patients who were being put on pirfenidone were essentially saying you've got to have no exposed skin whatsoever, and if you do, you've got to put factor 50 on at all times. So a game changer, but far from perfect. And in the same publication in the New England Journal of Medicine, we heard about nintedanib, which was published at the same time in 2014, and this is the second antifibrotic drug, which again, for the first time, changes the natural history of this condition. And these are similar slides. It's slightly unclear. This is what happened to the patients who took nothing, and this is what happened to the patients who took nintedanib. So, clear difference between doing nothing, but far from perfect, that the condition is still getting worse, albeit at a slower rate. But again, at a cost, with 2/3 of the patients getting diarrhea. And the kind of conversations that we have with our patients is, yes, we can give you extra years of life, but you may be spending a lot of time in the toilet. And not all patients have jumped to taking these new tablets because it's not only about quantity of life, it's about quality of life. So we are now in the last 5 years in what we call the treatment era of lung fibrosis. For the first time, we now have therapies that we can advocate. The Australian government was slightly slow on the uptake and have only released them to clinicians in the last 2 years, many years after these drugs became available in other countries. But we are also recognizing that we are really keen for the next era of therapies that may become available. We know that what these studies show is that they affect what's called the forced vital capacity, or the size of the lungs, but it's not immediately clear that this kind of medical measurement actually means that the patients are happier, have a better quality of life, although they do appear to live longer with it. And we are aware that there is a cost, as I've just said. We've taken these drugs, and it's all very well giving people extra life if there's no quality of life associated with that. So that has become a major area of interest as we move forward into the new era of treatment for idiopathic pulmonary fibrosis. And there's a lot of publications addressing this. You know, how are we going to develop the new drugs? What are we wanting from the new drugs? We want improved efficacy. We would like to halt the condition, not reduce the deterioration. We want to halt the condition, and ideally, we want to repair the lungs, so the lungs actually go back from where they were before you had this condition. And we want to do it without the side effects that are seen with the current drugs. And when we look at the endpoints in these studies, it's not just about coming up with numbers, the size of the lungs, how well the lungs work. We need endpoints that mean something to the patients, that the patients have an improved quality of life, that they are happy that they're going to be longer. So there's a lot of discussions on how we should be designing the new trials looking at treating this condition. So this is, again, just a summary slide. And Steve will go through this in a little bit more in the next presentation. But this is a kind of medical, if you like, scientific description of how we understand this condition. And I put it up there not to drill into the detail, but to just show it's a relatively complex slide. And I think that reflects that we understand that this is a complex condition. And there are many pathways that we need to address before we finally get to the holy grail of a therapy that not only halts the condition, but gets the lungs back to how they were beforehand. And there's a lot of interest. There is a lot of work, a lot of science being done in this condition with a view to coming up with the new therapeutics for this condition. And these are just an example of some of the pathways that different groups around the world are looking at to try and come up with a new generation therapy for this condition. And it's worth saying that we would not have put any slide like this up 10 years ago. There was really a nihilism with regard to this condition 10, 20 years ago, based on the fact that we've had many decades of failed therapies, and everything we did actually made the patient worse rather than better. I think this slide is in the brochure that's with you, but again, it illustrates it's not just the scientists who are doing a lot of work in here. There's a lot of biotech companies, there's a lot of pharma companies who are investing in this area because they recognize we have a much better understanding of the condition and that there is the hope that we can get better generation drugs to treat this condition. And it's worth also just mentioning the point that whilst I'm largely talking about idiopathic pulmonary fibrosis, which is a relatively rare condition, everyone recognizes that if you can reverse scarring, you can reverse fibrosis, and you can do it in the lung, these same drugs may also be efficacious in other organs in the body, such that the drugs that you develop in the lung may help cirrhosis, may help renal kidney fibrosis, may help skin scarring and skin fibrosis. So I put this up because I think this is, in essence, is why we've collaborated with AdAlta, or maybe the other way around, why AdAlta have collaborated with us, is that what became apparent is that as companies were going through the drug discovery pathway, and I put this up as an illustration, that somebody comes up with an idea in the lab, and what they then go on to do is kind of demonstrate some benefit in this drug in a mouse model or a rat model of the condition. What many drugs were doing historically were then jumping from a mouse data straight to human trials. And it doesn't take a genius to realize that what may happen in a mouse doesn't necessarily happen in a human. And a number of companies were basically ending up with negative clinical trials because what happens in the mouse doesn't necessarily happen in the human. I think what AdAlta recognized a number of years ago is that they wanted further validation of their molecule and their therapeutic in a human model. And that's why we got to do some work looking in human lung tissue. The reason we do that and why we've ended up collaborating is that I work at the Alfred Hospital in the respiratory unit there. I wear two hats. I work in the lung fibrosis clinic, but I also work in the lung transplant clinic. And we have one of the world's busiest lung transplant programs in the world, where we do 100 lung transplants a year, 2 a week, of which about a third of these patients have idiopathic pulmonary fibrosis. And what historically happens when somebody has a transplant is you take their old damaged lung out, and essentially it goes in the bin. But what we created almost 10 years ago was a lung tissue bank, where patients with idiopathic pulmonary fibrosis who are going forward to a life-saving transplant, when their old lung came out and was of no use to them, instead of it going into the bin, we basically stored it and have used it as a research tool to advance research into this condition and other lung conditions across all of Australia. And what we've gone on to do is a series of validating experiments using human lung tissue, but not only human lung tissue from patients with IPF, but also comparing it to human lung tissue that we get from healthy individuals, which we get from a different avenue. And I'll finish with just a couple of summary slides. I do not want to spend too much time on the science, but what we're able to show is that CXCR4, our target molecule, if you like, really you don't see it at all in a normal lung. This is what a normal lung looks like. The lungs are like big balloons. They're supposed to be full of air. And these areas of whiteness are basically where air can be entrapped within the lung. This is what a fibrotic lung looks like. It looks solid. Try putting air through that. And you can just see dramatically the difference between a normal lung and a fibrosed lung. And the stain we're looking for, if CXCR4 is there, it changes brown. And all these areas here at relatively low power show that the CXCR4, this target molecule of interest, is not within a normal lung, but is within a fibrotic lung. And when we look down at high power, we can show which parts of the lung where this CXCR4 is. And we've been able to show that CXCR4 is not in normal lung, it is in IPF, and of interest, it's also in the lungs of those other 50% of people who have lung fibrosis, but it's not due to idiopathic pulmonary fibrosis. They may have fibrosis for other reasons. So again, it raises the possibility that if a therapy is effective in IPF, it may also be effective in some of these other lung conditions that are characterized by scarring of the lung. And we've gone on to, again, I won't go into detail, but we've been able to show that even within a fibrosed IPF lung, there are areas of normal and there are areas of scarring, and the CXCR4 is nowhere near the normal areas, it's just in the fibrosed areas. And this is ongoing work that we're aiming to publish. So I will finish there. I'm happy to take questions. I'm a much happier person than I was 10 years ago. It really was a miserable clinic 10 years ago. All we did was we confirmed you have a condition, it's worse than lung cancer, and there's nothing we can do about it. But now, with a greater understanding of the condition, we actually have some therapeutics, but because we're greedy, we want better therapeutics, and we want therapeutics that have got better efficacy without the side effects. And I'm optimistic that 10 years from now, we will have that. Thank you very much.
So does anyone have any questions for Glen? Mike, up the back, right up the back. Right up the back.
Thanks for that, Glen. That's really interesting. One of the questions I have with regards to the kind of experiments you can do at the Alfred Tissue Bank, can you maybe let us know what kind of insights you can derive from that kind of work and how that's potentially helpful, to inform AdAlta's way forward?
Yeah, so our first line of experiments are really demonstrating what we've shown there is the target molecule of interest in an abnormal fibrotic lung and not in a normal lung. And it was reassuring to see that that was the case. And then what we've gone on to do is, and this is ongoing work, is we've kind of drilled down on some of the cells that we think are driving the fibrosis. And we've got ongoing work to see the impact on not only the therapeutics that AdAlta, but also the other companies have, on whether or not they affect some of the other cells, whether it's the immune cells, whether it's called the fibroblast. The fibroblast, I don't want to get into too much science, We think the fibroblast is this abnormal cell that is churning out this scar tissue. And we've got ongoing work looking at the impact of therapeutics on that cell. So there's a series of experiments. We can also do gene expression studies as well. So when we get a whole lung, we basically, not only do we do staining like that, but we get the cells and we store them, and there's this whole series of studies that we can do. And again, just to promote myself, seeing as I'm here, what we've done is actually come up with a series of experiments that we do and a kind of promotional pamphlet that we hand out to companies like AdAlta, saying that this is what we can do to kind of fast track your product of interest to a point where you've got confidence that there's efficacy.
And you can compare that, I take it, to the existing drugs, pirfenidone and...
Yeah, absolutely. Because those drugs are easily available, we essentially just buy them from our pharmacist, and we can do comparative analysis with pirfenidone and nintedanib. And then I briefly mentioned, we also have an archive of so-called normal human lung tissue, so we can do comparisons. Not only is what happening in lung fibrotic tissue, but what's happening in human tissue. And again, you want to see differences between the two.
So Mark.
Yeah. Is it expected that inhaled drugs would have a better effect than systemically taken drugs?
Yes, possibly. So there's still some debate whether or not the fibrosis is being driven by what's called the epithelium, which is the first part of the lung that's exposed to the airway, if you like, or whether it's driven by something that's deep within the lung, a long way away from something that's inhaled. So there's still debate whether or not the major driver, the major abnormality is deep within the lung, in which case the inhaled therapies are not so good, or whether it's a primary abnormality on the lining of the lung, in which case inhaled therapies are absolutely there.
So pirfenidone's being
pirfenidone is being tested, and we've been involved in the phase 1 studies of inhaled pirfenidone to see whether there's efficacy there. So yes, there's interest. But it's not clear cut exactly where the therapy may be 10 years from now.
Is there a question of access in IPF patients with an inhaled drug, given the collapse of the airways?
Yeah, so again, it's to the point, is that if you inhale something, it will get only to the outside of the car, if you like. It won't get inside the car. And it's whether or not we think the abnormality is on the, I'm saying the outside, but it's on the inside. It's on the inside, but the inside of the lung that's exposed to the environment. So, asthma, for instance, is a classical disease where it's very much about what's called the lining of the lung, and all therapies for asthma are inhaled therapies. It's not deep in the lung. So it's not clear whether pirfenidone is more like asthma or some other lung conditions. That makes sense.
So, Glenn, I had a question about the time of onset of the symptoms. You said is classically sort of mid-60s. How long before that, though, do you think this fibrotic process has started?
I think it's probably many years. The lungs have this phenomenal reserve that you can lose half of your lung, and you may not know about it unless you're very active. If you're an elite athlete in your 60s, you might notice that your triathlon times are coming down by a minute every month. But I'm not a triathlete, and I wouldn't be aware of that. It would be when I rushed for the bus and I couldn't do it. So most of our patients, we actually think, have probably had the condition for a long period of time. And there's some big population studies where people have had CT scans for other reasons, and there's been scarring many years, and sometimes decades earlier. So we think, and this is one of the problems, that often when we hear about these patients, they're relatively into the course of the disease.
But it would be advantageous to start to identify these patients and start earlier.
Absolutely. I think intuitively, the drugs do slow the progression. If you're slowing it down at the 11th hour, the horse has bolted. If you slow it down at an early stage, well, then you prolong life. Possibly it's more receptive to therapy at an earlier stage than when it's just scarred. Your drugs are going to be less beneficial in that sense.
And inhalation will be possible in the early patients, maybe.
So,
thanks, Glenn. Perhaps this is an unfair question. Why do you feel that AD214 is a good candidate for treating IPF?
Yeah, well, I think it's, basically the data we have today is ticking some of the boxes, but, it's likely to be efficacious. One is that it's not there in normal lung. And when you look at the IPF lung, it's very bright in the scarred areas of the lung. And as you know, to the earlier question, what we're doing is trying to get a sense of what would happen if you knock on the CXCR4 and the CCR4, and they're the functional studies that are ongoing.
So do you feel that it cures the IPF, or does it just retard the fibrosis?
So the problem with IPF is, it's a bit like if you're, if you see somebody who's been involved in a fire, and they've got burns and their skin is all contracted. There's really no therapy, but once the injury has happened, you can't really reverse that. And fibrosis and scarring of the lung is a little bit like that. What we're trying to do, in a sense, is stopping that fire injury going up the arm, if you like, and causing worse. So you're trying to halt the disease. Now, whether in 10 years or 20 years we'll be talking about therapies that can unscar areas, that'd be great. But that would be, that's quite a step from what we're talking about. We're basically looking at switching off the fire, if you like, switching off the disease progression and halting it where it is. And to the point here, if we can pick patients early when they have good quality of life, well, then that's success.
Thank you.
You mentioned that there is room to improve the clinical endpoints.
Yeah.
Where are the limitations of the endpoints used in the studies that led to registration of the drugs that are currently available, and how do you see, what improvements do you see as possible?
It might be talk. A lot of discussion, without, I'll try and be quick, but to get a company into the marketplace, you have to get it into the US, and the FDA have said, who regulate drug studies in the US, have said, these are the endpoints you need to satisfy. The clinicians and the patients are saying, well, that's just a number. Why don't we start talking about quality of life and length of life? So there is this kind of to and froing between what the FDA is saying you have to satisfy and what actually means something to the patient. And that's an ongoing dialogue.
There's one more question up the back.
Just a quick follow-up to that. So in your mind as a clinician, where's the threshold for meaningful clinical benefit in your eyes for a drug like this that we want to be seeing, that'll make a difference to a patient?
So the real answer is asking Bill, and Bill saying, what couldn't I do last week that I can do this week? The simplest one is survival. So if you've got somebody living longer, that's great. If their lung function, and what we do is kind of functional tests. So we're getting people, we do what's called a 6-minute walk test when we see patients and show how far can you walk in 6 minutes, and if you then give them the drug and they walk twice as far, that's probably our best surrogate of quality of life, if you like. Because we're all active people. When you get lung disease, you become inactive, you get stuck in a chair. So if you can actually get people out of a chair doing stuff because they can do more, that's a meaningful output. But Bill can answer that better than I can.
Great. Thanks, Glenn.
No.